It is a huge honor today to be having the legendary Dr. John Chao, who everybody's heard of the Chao pinhole surgical technique. And there's, after our first 75 podcasts, we passed over 100,000 views. So I'm going to start with the man himself, the legend. I'm a huge fan of yours, but there's people right now in their headphones on a treadmill or driving to work who have heard of this a lot, but they actually have no idea what it is. So let's start with the basics. What is the Dr. Chao pinhole surgical technique? And it's also known by other names. So take it away, Doc.
Okay. Well, thanks a lot, Howard. It's a great pleasure to be with you on your podcast and to meet you finally face-to-face. Thank you for this opportunity. Pinhole surgical technique is a new novel way of treating gum recession. As you all know, gum recession has been so far treated with connective tissue grafting, which entails the removing a specimen from the palate and putting it where the defect is and suturing it together. And there are other variations of the technique, not using a graft from the palate, by using allografts or cadaver tissue to correct gum recession. So the pinhole surgical technique is a way to minimize the post-surgical symptoms, the morbidity associated with connective tissue grafting, which is considered actually the gold standard. So because of that, because the patients don't really like it, I'm sure if you have done any of these yourself, Howard, then you realize that the patients, generally, if they have one done, they don't want to do it again. And so this method that I developed actually calls for no cutting and no suturing and no grafting of any material, any tissue from the mouth. Basically, through a pinhole in the mucosa, I use specialized instruments designed for this procedure to to elevate a full thickness flap, removing the tissue from its bony connection along with the periosteum, and then detaching the attached tissue which, from the bone and from the roots. So I end up with a totally loose envelope of tissue. Then I can drape apically, I can drape from the apical direction to the coronal part of the teeth to then be able to cover the defect. And then without sutures, how do we do without sutures? We actually would put strips of collagen through the pinhole and then put the strips of collagen underneath the papillae. And then put it under the flap, and that stabilizes the flap, and just sit back and watch it heal. It heals really fast. The pinhole is gone in one day. And when the patient looks at it the same day when it's done, they think it's a miracle because there's no sign of surgery to them, because to us it looks a little swollen. Outside of that, there's hardly any problems with bleeding, hardly any problems with pain, and so the patients just love this minimally invasive procedure. So,
how did you invent this? When did you invent it? And how many year follow-ups have you seen on this? I mean, how long does this last? Walk us through the history story of this.
Okay. Well, many things happen.
Did they teach you this at USC? Was it a lecture at USC when you invented this, or how did this happen?
Well, I was very interested in tissue regeneration, and I had taken quite a few courses on it at different places, not at USC, but at CE courses for that. And I remember one time I had taken this course, and actually bought this special scalpel that's parallel. You have two blades parallel to be able to take a sliver of tissue from the palate. And I took it out and very carefully. I placed it on to the root of the upper right cuspid, and I turned around to pick up the needle to suture, pick up the hemostat to suture, and I heard this sound go. You know what that means, right, Howard?
They swallowed it.
No, the assistant suctioned it up.
Oh gosh.
I said, I was not about to go to the pallet and take another piece, and so I was in the quandary. But finally, I was able to get some Alloderm from the fridge, and I was able to finish the case. So that was kind of traumatic to me. So I said, no, there's got to be an easier way. It's got to be easier for the doctor, and it's got to be an easier way for the patients. And so I began to study all the different types of surgeries, search the literature, and it occurred to me that very few, if any at all, procedures allow you to start from the mucosa where the tissue is soft, and approach the attached gingiva where it's harder. And I realized that just might be a way to do it. And so I began to put incisions at the mucosa of the teeth, and I began to see relatively good results. The incisions had to be large, and then once you make those incisions, you have to suture them. So they kind of pulls the flap back. But as I begin to narrow the incision, make it smaller and smaller, I realized I can get better and better results. But as the aperture gets smaller, I was unable to elevate the tissue properly and get the results I wanted. So I realized I had to develop new instruments, and that took the beginning of the concept came to me about 2000, and it took me about 6 years to work out the instrumentation to make it work. So about 2006 is when I was able to formalize the protocol and start recording what I do. And the recording then eventually became the subject of my study that I published.
Now, we put up 307 one-hour courses on Dental Town, and they just passed 500,000 views. Any chance someday you would put up a course on Dental Town to show this?
I would love to be able to talk about it, but this is actually a hands-on technique.
Oh.
You have to be here and hold the instruments, and let me walk you through it. Actually, really, literally hands-on, and we use freshly thawed cadavers that's not embalmed, mounted on the chair to show the doctors how to do this. Now, if you follow, it sounds complicated. If you follow exactly what I teach you in those 2 days, you should be able to do it quite easily and really incorporate that into your practice.
So how can someone find out about your course? Now your website is pinholeacademy.com, Pinhole academy.com.
Yes.
So if I'm driving to work right now and listening to you in my car stereo, if I logged on to pinholeacademy.com, I could find your courses. Or are they pretty much all where you practice in Alhambra, California, which is a suburb outside of LA?
Yes. It's the hands-on training is done in my office. We have 9 operatories fully equipped with monitors to show the doctors what to do. But the lecture part, we go to the facility of a nearby golf course where we do the lecture activity. So we do transport the doctors back and forth from the lecture location to my office.
And how many doctors are usually? What is this course class size limited to?
It's we limited to about 30, where I can adequately train them myself with my staff. So generally, it's about 30, a little bit more, a little less sometimes.
And how much is that class?
The tuition is $5,000.
And what?
For 2 days.
And what for 2 days?
Yes.
And how much do you charge? How much would a patient pay for this procedure? I'm trying to figure out how many cases would a dentist have to do to recoup their $5,000 investment in your 2-day hands-on course.
Yeah, that's a great question. The ROI is terrific. The return on investment is terrific. If you use connective tissue graft, you probably can do 1 or 2, maybe 3 teeth at one time. And but with the pinhole surgical technique, it's actually better. if you do a full arch. So you could do 10 teeth. And hypothetically, let's say if a doctor charges $1,000 for a tooth to do connective tissue grafting, you could take a case, an elderly person, let's say within about 50 to 75 years old, they generally have multiple sites of recession. You could use the pinhole technique, pinhole surgical technique, to actually do a full arch, do 10 teeth or 12 teeth. And then you can say, well, whatever I charge, because it takes me much less time, you can charge less per tooth. So potentially, if you do 10 teeth in round figures, you could charge $10,000. But of course, you can say, well, it takes me only an hour and a half and 2 hours to do it, so I'll charge a minimum of $500 per tooth, and that will be a $5,000 case.
Okay, so let's start at the very beginning. Let's start all the way at the very beginning.
Okay.
Why? I mean, because you graduated in '67, so there's 5,000. These podcasts are huge in the young kids out of school. The first 5 years, they're the early adopters of the podcast. So let's start at the very beginning. What causes gum recession? Why do they have? Why do they need this surgery? What caused it in the first place?
Well, the etiology is that it could be anatomical. The tooth is just not located at the right place out of the alveolar process. It could be sticking out. That could be anatomically the problem. It could be that way because of orthodontics. That's another cause of it. Or certainly inappropriate brushing, overbrushing, underbrushing, neglect, periodontitis. It could be chemical erosion. It's been attributed to malocclusion, bruxism, and there's debate about that. So there are various causes that will need to be identified, but it's so prevalent. Actually, it's 1 out of 2 adults in North America, in fact, across the world, have some degree of recession.
I want to ask you about the one of the big controversial debates on Dental Town is whenever you say that this recession can be from overbrushing, a lot of dentists say no, it has to be abfractions for malocclusion and bruxing and grinding, because when you look at animals that don't brush their teeth but are herbivores grazing, that they have the same abfractions too. Have you heard that, or have you read that, or what is your thoughts on that?
Well, I would, there's valid arguments to go both ways, Howard, as to what caused it. I will know this. I know this, that once you have made the surgical correction, you have used the penile surgical technique to correct the problem. If the patient continues to overbrush the area, you'll definitely lose it. And you can lose it. You can use connective tissue graft and graft an area. The patient can also destroy that with overbrushing. That I've seen. That I know is true. Now, what brought it about? It's such a multifactorial situation that it's hard to say. Oh, in one situation, it may be because of overbrushing. Other situation, it's not. I think probably some people get recession without overbrushing. Some people get recession just because they have teeth, where there's no occlusion at all. Sometimes on the anterior teeth, open bite, and there's no evidence of overbrushing, and then you have recession. So actually, according to studies on etiology, there's about 17% that's unaccounted for. There's no known etiology to explain why you have that. So it's kind of the etiology part of it. It's very debatable. It's all over the place, but it doesn't change the fact that we have recession to deal with. And
well, that's a sign of a great not mind, because when we're little and we're children, we're taught binomial. Everything's yes, no, left, right, up, down, and the true sign of an educated man is that it's multifactorial. You even said 17%, 1 in 5. We don't even have an etiology. There's just, we always know what we know, but we never have any idea of what we don't know. So, but back to patient, I want to go back to patient selection. What patient is most motivated to want to do this? Would they be the ones with sensitivity, to, the recessions causing hot and cold or sensitivity, or in what percent of these recession does have sensitivity, and are those the most likely to want to have some correction, because it's hard to get a patient motivated to fix a problem if they don't perceive it's a problem. So talk about case selection and sensitivity and case selection.
Okay, very definitely, Howard. If you have severe recession, severe sensitivity, you drink something cold, it bothers you, it hampers your eating, then of course you want that taken care of. But people come in for recession correction for different reasons. I think one of the central reasons that I see is cosmetics. You have a high smile line, you smile and it doesn't look right. Something like this. This patient actually came to us. She's a dental assistant. She came to us with recession, and she actually puts her hand over her mouth when she smiles. She really feel handicapped as a dental assistant, not to be able to smile wide and be able to help other people with their smiles. So she came to us, and it so happened that we were asked in 3 days to be on the doctor show, a national show that it's a little bit like Dr. Oz, the show that goes across the country, and so they asked us for the weekend to do a pinhole surgical technique operation on the patient. So we're not going to turn it down, and we'll see who happened to be there, and so we had to come in. We took care of her. And with the camera on, we were able to do 10 teeth in about 57 minutes, and that's on the show. You can find that tape actually on my website. So
on the Dr. Oz show,
there's two shows. One is Dr. Oz, and one is just the doctors. We were on the doctor show.
The doctor show.
Yeah.
The doctor show. And on your website, is that on, is that when you post that video, is it on YouTube?
It's on YouTube also.
Because that photo you held up, you can, if you started a thread on Dental Town and said, the Dr. John Chao, Rossio before PST being pinhole surgical technique.
Yes.
You could start a thread and post that as an image, and you can also drop in the link to the YouTube, and it'll pull the whole video up inside of a thread.
Well, thank you, Howard. I will do exactly that.
And I can put that on an email blast and email that to 85,000 dentists. So that's Roccio, ROCIO, 1 hour after pinhole surgical technique.
Yeah. Now Rossio, but so we were able to do that. Rossio, and this is 57 minutes later. It looks like this.
And lift it up a little bit higher. Oh wow.
Okay, before.
So one pinhole on each side. Yeah, that's amazing. If you're listening to this right now on iTunes or sound only, you're gonna have to log on to Dental Town and see these before and afters. This is amazing.
Yeah. So this is the next day. Now this is okay. This is
6 months later.
okay. So these pinholes are pretty much gone the next day. So the patient, when she saw this, she actually cried. So talking about the etiology and what kind of patients do come, and they come because one of the main reasons they come is because they want a better smile.
So cosmetics so that's the main reason.
That's one of the main reasons. They come for a variety of reasons. Sometimes they just, they're actually the best patients you can find, because these patients come to you to say, I'm disturbed. I don't like my gums being receded. I don't like gum recession. And they don't even see it. They actually have to pull their cheek up, the lips up, to be able to see it. And these patients, they know something's wrong. And maybe they've been told by their dentist that they need something done. And maybe they were told that they need to be referred for grafting. and they either don't go or they went and didn't want it done. So they look up myself and about they have a choice of about 850 dentists now who have been trained, and they look them up and to go to them for taking care of this problem. So the sensitivity is definitely one of them. Cosmetic is another. Sometimes it's just they realize they've been having too many fillings done on the same tooth, time and time again. So it's people who are aware and concerned about recession are the ones who are really the best patients that anybody can find.
Now, what about sensitivity? What percent of patients who have this recession, about like the case you saw, how many of those people actually have recession, and is that a driving force in this surgical technique?
You mean as far as sensitivity, Howard?
Yeah, because some people have recession and no sensitivity, other people have recession sensitivity. What percent of people that have this recession have sensitivity? And do you think that's related to a different etiology, like more have to do with bruxism or grinding versus erosion from acid from bulimia or orthodontic malocclusion, that the tooth's not in the right socket?
Yeah, I definitely have get a large number of people coming in because their teeth are sensitive, and that's what alert them to the problem. But in terms of actually saying, well, that is actually the cause, that recession is directly related to the sensitivity or vice versa. It's not that hard to, it's not that easy to pinpoint, because a lot of it is from bruxism, I believe. I was very involved and still am in TMJ for many years. I know what can happen when you brux, and a lot of times what we do is we actually check the teeth which are recessed with, let's say, a piece of ice, and then we check all the other teeth, and oftentimes all the teeth are sensitive. It's just not the teeth with recession. So I don't have the stats as to how many people, what percentage of people come in for sensitivity of the roots where there's recession. There's sensitivity sometimes, more often than not, the sensitivity everywhere. So I'm realized that when we treat people for recession, we have to look at the occlusive factors. At least if we don't agree that the etiology is not occlusion, let's say somebody has that conviction, then no, everybody agrees though that during the healing period, during the first 6 weeks, and then actually the first 6 months, while the tissue is maturing, that should be no disturbances to the wound. You cannot have a stable wound if the teeth are somewhat moving, even to a very minute extent. So I do look at the occlusive factors as a very important feature of post-operative care. That I make sure if they needed bite guards, if the lower interiors I'm treating for gum recession are slightly mobile, that I would do lingual stabilization, lingual bracing, and so on. So there's a lot of so occlusion is a very important part of my diagnosis and treatment as far as pinhole surgical technique is concerned. And we'll go over that very extensively during our 2-day course.
Well, talk more about that, because when a lot of people treat occlusion factors, you hear bite guards, some do them upper, lower, some do them hard, soft, some use the NiTi. What's your protocol on all that?
I generally prefer lowers because if I do want them to wear during the daytime, it doesn't hamper the speech as much. So just out of long-term use since the 80s, I generally do use a lower, but if I feel that there's actually mobility, let's say in the upper interiors, I don't want them disturbed, then I would put an upper on. So I find that the patients get along better with the lowers than with the uppers, but that's my personal preference as far as as far as upper and lowers. Then I do make a cast frame orthotic appliances or bite guards sometimes, because patients don't like that bulk that comes with the with the acrylics that we made the bite guards out of. So I use different kinds. Sometimes I'll use something with just a lingual bar, and during the with a side saddle during the daytime, I give them a full bite guard at night. So it's all different, and I talk about the different ways the doctors can actually address this problem with occlusion or with bruxism during our 2-day course.
And what do you think about some people do an equilibration? What do you think of the equilibration versus wearing a lower night guard?
However, with teaching the pinhole technique, I'm just looking at I'm looking at a whole spectrum of doctors who hold different beliefs as far as occlusion. But I would say to the doctors contemplating a pinhole surgical technique that they narrow the spectrum. I narrow my spectrum to the teeth getting that surgery. The teeth getting pinhole surgical technique, I'll look at those. How can I keep those teeth stable during the healing period? So if it requires coronoplasty, if it requires equilibration to get those out of hyperocclusion, I would not hesitate to do that. As far as equilibrating the whole mouth, personally, I don't have a problem with that. You need to know what you're doing. You need to be well trained. You need to know the basics and do your workup properly. Probably now the cone beam is so readily available. Certainly do a cone beam, and to be able to visualize the TMJ from different directions and have a 3D image of that. So if you do the protocol right, I don't have a problem with equilibration as a preparatory step to doing pinhole surgical technique. But if you don't believe in equilibration, and I would suggest that at least take the teeth being surgerized out of hyperocclusion.
You're also very interesting. You patented this technique, and you're an attorney. So, I mean, after dental school, you went on to law school and became an attorney, and you patented. Talk about that. What made you go become an attorney after dental school from USC?
Well, actually going back, I think the thought came to me when I was doing TMJ work. Doing TMJ work led me into the courtroom because I was the treating TMJ dentist for a lot of patients who had accidents in the car mostly, or even at work, and they come to me for treatment, refer by other dentists and even their attorneys to represent them in their claims against insurance companies. So I began to interact with the lawyers, and I realized that it's kind of interesting. I like the concept, and I feel that I was on par with whatever they are actually bringing to the courtroom and to the depositions. And I got more and more interested. So finally, I said, you know what? I like to have a broader view of life. Even though I was not particularly interested in practicing law, I said, well, I need a challenge. I was getting, in that period of life when, you look for something different to do, a different challenge. So finally, I decided to go to law school for 4 years, night school. I kept my practice going. And in fact, I was doing a lot of TMJ at the time, so I could afford to be away from the office. And then after I finished, I passed the bar in California. And then I realized I love dentistry more than ever. I really don't want to practice law. But I like to teach law. So I've been teaching dental jurisprudence all across Southern California. And I also took a position back in a few years ago with USC teaching dental jurisprudence to the classes there, and eventually they also invited me to teach ethics. So I'm also involved in the teaching of ethics as the co-chairman of the ethics department at USC right now.
That you have such an amazing career. I mean, you really are an amazing man. When I talked about an online CE course on Dental Town, you said that this is really a hands-on course, but the way I see it is this. The biggest financial asset most all Americans will ever have is their house. And when grandpa dies and it's just grandma and she's on a fixed income, needs more money, an annuity is really usually a good thing. She can sell her house to an annuity and then get a monthly payment, and they try to and if she lives to be 100, she wins, and if she dies the next day, they win, and it all works out. But to get grandma to do this, it's the biggest decision in the world. So they run a commercial with a trusted figure, and they just try to get her to just call a number and get a DVD, and they swear no one is going to bother her, and she's just going to get a DVD. And they deconstruct the sales process. Then the DVD explains the whole process, and all it says is, if you just call this person and tell them where your address is, then they can tell you your monthly payment. And so it deconstructs the sales process. And I just think a lot of dentists should take your 2-day course, but it's so big of a decision to go from I've just heard about it to I'm going all the way there. I think if you put a 1-hour course on the Pinhole Academy, it will deconstruct this process, and they'll sit there and after 1 hour say, okay, now I'm ready to commit to getting an airplane, flying to Los Angeles, and spending 2 days with the legend himself, Dr. John Chao, and learn this Pinhole surgical technique. I'd like to get that course out of you, and I'd like to get a jurisprudence course out of you. I bet that would just be amazing.
I would love to do both. In fact, right now we have been doing webinars on the Pinhole surgical technique on a monthly basis for the last 3 months already. And your idea is actually very, very good. Is that they need to see actually. Seeing is believing. You have to see this to see what you can do, and we don't just show what I do. I really. In the webinars, we show what everybody else does. The doctors, such as this case here. This is a doctor. He took care of this very severe recession.
Wow, that is amazing.
And just after the 2-day course, and this is just another one. This is a doctor from Italy.
Hold that up a little higher.
This is a doctor from Italy.
Nice.
We have doctors from all over the world. Mongolia, Korea, Dubai, from everywhere, coming to see us for the 2-day course so that they can bring it to their patients. And so we have so it is absolutely, I think, important for a lot of doctors to know what they will be getting. What is it? How can they be assured that if they took the course, that they can actually do it themselves and be able to really effectively bring it to their practice, and actually to be able to draw patients. Howard, there is this is a very unusual method, because as far as I know, there's never been a root coverage periodontal procedure that patients actually demand. Where millions of people have been exposed to this already, they actually call up and say, I want this particular procedure by name. I want Pinhole, otherwise I'm not coming. And so we want the doctors to know that the reason people like it is because it is scalpel-free and suture-free. The public knows that this is much less invasive. They're much more willing to accept this kind of procedure than what they view grafting as. So we do have a whole bunch of people waiting to find pinhole dentists across the country. We even have a doctor, interestingly enough, that called up and said, Dr. Chao, take my name off the Find a Dentist portion of your website, because I'm just getting too many patients. And they're calling in from areas too far from me, and I really can't service them well. So he was getting so many calls that he actually didn't want anymore. But generally, the doctors are very grateful, very happy that they do get patients who want this technique and ask for it. And these, like I said, are the very best patients in the world. They want good health. They're concerned about the recession, which may or may not be symptomatic, but they want that situation corrected. And they're very sincere. They're willing to drive miles and miles and fly from other cities and states to go to the dentists who are trained for this procedure. So I love to share that on the webinar on Dental Town, and I love talking about dental jurisprudence and the medical legal aspects of dentistry, which I think could really be used by a lot of the dentists. If they only know the rules of the road, they can operate so much better and be so much more successful if they only knew. But Howard, you asked me about patents. Would you want me to talk about why I patented it?
Yes, I do. What is patented? Is it the instruments or the whole technique, or what's the patent?
Okay, and I patented the instruments, which is not unusual. But because of my background in law, I was able to dig a little deeper with my patent lawyers at Foley and Gardner, and we realized that the law does allow us to patent the method. You're allowed to patent the method that you develop. Well, it's just like if you develop software, a software program that's totally new, you're allowed to patent that. So you can patent a method. So when I apply for the instrument, which also describes the method, I patented the method at the same time. When you patent the method, you have to describe how you use it. So why not patent both at the same time? Now, why did I want to patent the method? I knew once I finished the invention of this technique with the instruments, there's just no way anybody can read a book, can read an article, and use instruments which I didn't invent, and try to duplicate the effect. I knew that this was not going to be possible, and I didn't want the method to fall into hands which may not do good for the patient. In other words, I'm thinking now this method should be disseminated in the correct way so that patients are really served and not be adulterated by sources that can take it and misname it, misuse it, adulterate it, and actually visit harm on the patient. So I patented this so that I can have control over the method, over its teaching, so that people who are practicing this method can do it safely and competently and get the result that I get. And I strongly do not recommend anybody do this method, do the pinhole technique without instruction, because that really puts the patient at jeopardy and puts the doctor at risk for doing the pinhole technique in an unauthorized way. So I wanted this opportunity to explain why we patented it, so that also the other part, Howard, is that once you're trained to do this, you've invested your time and effort to do this, you should not be faced with unfair competition from those who have not taken the time and the effort to learn how to do this right and try to compete with you on price. And we've seen that happen with implants, how that really went out of control, and you can have an implant for $395 to $2,000, and it goes, and it's just everywhere. It's a wild west out there, as far as I can see implants. What do you think, Howard?
I agree with your point. I'm trying to estimate, what the listeners thinking out the field, and I bet you a lot of people are wondering, what if I'm not a blood and guts person, or how much surgical skill would I have to have? Would I have to be able to? Would you say, as a pre-requirement that you pull your own wisdom teeth, or you place dental implants, or you can at least how much surgical skill would an ideal candidate already have before they make the journey to California and see your hands-on course?
That's a great question. If you know how to extract teeth, not necessarily a wisdom tooth, certainly that calls for a maybe a higher level of surgical skills. But if you know how to extract a tooth, that's the basic skill that you need to bring forth to this course. If I were in a webinar situation, I can actually play a tape for you. We have actually a tape that runs 7 minutes, where I actually take care of one recession in 7 minutes with a collagen, without cutting, without suturing, and so it is not a real difficult skill to master. You can actually be competent at it within 2 days, but it's a totally different concept. And if a doctor is willing to follow a strict protocol, then I don't see that doctor is going to have a problem being able to take my course on Friday and Saturday and be able to do it on Monday morning for one of his patients, because we have made it so seamless from the method to teaching on the typodont of the pig jaw to the cadaver mounted on the chair side, and go through every part of the mouth where you'll be using the surgical technique, and be able to then allow you to feel confident when you leave that you can repeat that same situation on a live patient on Monday. So I don't see any problem with basically any dentist who coming in with a minimum of surgical skills.
So as long as you feel comfortable enough to extract an incisor, canine, or bicuspid, you could learn this technique.
Yes.
Okay, and I want to. So now the other $1 million question, I'm sure everybody's wondering. There's 9 specialties recognized by the ADA, 7 clinical, 2 non-clinical. What do the 5,000 board certified periodontists think of your technique? Have you heard from them?
I've heard a wide spectrum of opinions from them, and some very, very supportive, and some just as not supportive. But overall, we have trained 5% of the membership of this society of 5,000, 4,000 periodontists in the last 20 months that we've been giving courses. So more and more.
Wow, 5% of the periodontists. That's impressive.
Yeah, so we have about 250 periodontists who have been here and been trained, and now they're practicing the Pinhole surgical technique actively, and so more and more I see their colleagues coming around to accepting this new way of doing things.
Now, a couple more questions on periodontics. You're a general dentist, correct?
Yes, I'm
okay.
a general dentist.
Okay. LANAP has been. I don't even think have 5% of the dentists even learned LANAP. What are your thoughts on LANAP?
I actually have the Millennium machine in my office. I've had it over 10 years.
I'm sorry. First, to our viewers, explain what LANAP is, and then tell us what you think. Tell them what LANAP is, and then tell them what you think of it.
Well, LANAP is a laser. It's a laser machine that has been shown by a couple of studies to actually regenerate tissue, in the pocket, and it's the only laser that actually has a couple of studies, histological studies behind it. And
what type of laser is it? Erbium?
It's an Urban YAG.
Erbium YAG. Yeah,
but it has different frequencies on it. You can actually turn it to, for different uses. You can actually dial the frequency that you want. So I use it. I use it primarily.
And you use the water lace?
I tried it for a few days. I didn't actually. That was quite a few years ago, and since I had the LANAP already, I didn't actually.
So what laser are you using for the LANAP?
They have the one model that I bought about 10 years ago.
But what's it called though? Just the LANAP laser? Or
yeah, it's called the Millennium.
Oh, the Millennium. Okay, Millennium.
They call it perio lace.
It's called perio lace by Millennium.
Yeah. Mm-hmm.
And is that BioLace?
No, that's a different company altogether.
Okay, so it's the Millennium Periolace, Erbium YAG, and LANAP. So you've been doing it for 10 years. What do you think of it? Is this something you recommend?
Well, that's straying out of my subject of expertise.
Right.
I do like it. I've actually used it in the first few years. I was getting pretty good results. If you follow the protocol, you'll find that what they tell you the results are. I shouldn't say you, but I followed their protocol, and I was able to get pretty good results. I do have to say that I have taken a different direction from just using the laser to using the laser along with endoscopy. There's a machine called perioscope.
Right.
It's like an arthroscopic type of a concept. You can put a tiny little lens underneath the gums, and you can visualize the pocket, and you can actually find where the calculus is. And they're using an ultrasonic instrument that you can remove the plaque that way. So I found it to be efficacious in my office along with the laser. So I actually use both to very, very good effect, to where I can take pretty hopeless teeth and be able to save them for the patient. So that's what I do. Of course, now it does tie into Pinhole because I do require our doctors to know to actually not use the Pinhole surgical technique where there's presence of periodontal disease or inflammation. We want the gums to be pristine. We want really, really healthy situation so that we can get the best results. So
who makes the perioscope?
The perioscope is made by the Millennium. They call it the Millennium, located in Periscope. Oh, I'm sorry. That's by John Kwan, a periodontist in San Francisco. It's called. You can look it up. And you can find perioscopy.
Perioscopy is the company. Perioscopy. John Kwan, Q-U-A-N.
John Kwan. It's called. It's the company's name is actually Danville. D-A-N-V-I-L-L-E.
Oh, Danville. Yeah, they make microetchers.
Yes, and they own it right now. It's been through more than two hands. I think John Kwan is the periodontist who's heading it up, and he's how do you spell him? K-W-O-N. It's a K-W-O-N-G. John Kwan. I wasn't prepared to talk about this, so I don't have.
Oh yeah, is he?
K-W-O-N.
Is he a friend of yours?
I only know him through my dealings with him with Perioscope.
Yeah, I saw that Perioscope. That's been on at least 10 years, hasn't it?
Yes, I had the machine back more than 10 years ago, and then because of lack of support, somehow the company was not able to support its maintenance. It kind of died off, and then about so Dr. Kwan then took it over and modified it and improved it. And so with a new version, I had a new version about 3-4 years ago, and it's worked out very, very well.
And what percent of when you're doing your pinhole technique, when you make your pinhole incision, what percent of the time do you actually scope up underneath it and take a look around with an optical scope?
I have not done that at all.
You've never done it at all?
No, I have not done it because for this reason, you have to the way you can see what you need to see under the gums is because there's a water spout that cleanses the lens with water, and with what I do, I cannot be pumping water, underneath the pinhole. I've thought of it. That's a great idea. I actually thought of it, and I couldn't use it because that was to introduce something with water into my flap, and I didn't want to do that.
Well, I think it's just unbelievably impressive that you've got 250 periodontists to learn your technique. I mean, if that doesn't speak volumes for what you're doing, that is just amazing. So we're 50 minutes down. I've only got you for 10 more minutes. A lot of dentists, humans, they need inspiration, they need motivation. A lot of it's not just knowledge base. So in your last 10 minutes, try to pump this doctor up of why she should learn more about this. What would her first step be? Would you recommend that she goes to pinholeacademy.com? And do you have some of those webinars already posted on your website? I mean, have you posted any, have you filmed, and can you see those webinars, or is webinar something you just have to see live?
We have a lot of videos of patient testimonials of what I do, and a lot of videos on the website. and so you can find them very easily. But in fact, we have a webinar. We have a webinar every month, and so we do show videos there also. But what the doctors will find inspirational, very, very interesting, is the patient reaction. Just the other day, we had a periodontist on our webinar, Dr. Germanik from Orange County, and he said he's done hundreds of pinhole technique surgeries, and in the year and a half since he took the course, was one of the first ones to take the course. He says that this, as a periodontist, he does surgery, he never gets hugs. Now that he's doing pinhole surgery, he gets a lot of hugs. So he labeled it a pinhole as a huggable procedure. You do
wow, that is cute. A huggable procedure.
Huggable procedure.
I've never heard that term. I love it.
After you do surgery, you actually get hugs. And that's kind of goes across the board for most dentists. It's a way that we can show what dentistry can really do. Whether it's in the cosmetic zone, in the aesthetic zone or not, if you can show the patient, you can bring the gum line down in less than an hour to where it's normal, even though it looks a little swollen, looks a little red, and without sutures. Without sutures, that is something that they're totally thrilled with, because they know, looking at that, they're not going to have pain. On the average, our patients take about 2 over-the-counter pain pills for what we do, whether it's 2 teeth or 10 teeth or full mouth. They're very, very low in pain. So these patients are grateful. If you want to inspire your staff to bring a different level of energy, to your staff, do the pinhole. I'm telling you, it's just so exciting to see. And we dentists never get bored, right? When patients want to hug us, when patients tell us they're so touched and moved by what we do, and the appreciation they get from the patients will never bore anybody. So if there's one thing I would like to leave, with the listeners and viewers of this program, is that this is something exciting. This is something that you can do for your patients. You just need to invest in 2 days with me, and let me share with you my experience, and share with you the experience of doctors who sometimes come back. Some doctors now come back to get re-exposed to it, because now, since January, we instituted a freshly thawed, non-embalmed cadavers whose tissue is like real tissue, and they want to come back and really learn it, learn all the nuances that I can't teach. We're just using that. So for the doctors to get hold of us, go to pinholeacademy.com. Pinholeacademy.com, and phone numbers are there. The schedule of courses are there, and tuition can actually be financed interest-free for 12 months. So we have laid it out so that you can actually take the course and actually have return on your investment before even paying for the course. So we have made it very, very easy for doctors to come to us and learn this exciting, nearly painless technique.
Dr. Chao, you and I have practiced a long time, and would you agree with this statement that of all the specialties in dentistry, periodontics has changed the most? I mean, compared to like orthodontics or oral surgeons. I mean, oral surgeons are still removing wisdom teeth, but they're placing more implants. But don't you think periodontics has massively changed the most?
Well, I know it's changed a lot. I know that a lot of what it traditionally do has been dispersed into the practices of general practitioners, such as non-surgical training, non-surgical approach to treating periodontal disease, such as with lasers and so on. So you see a lot of changes. I don't know orthodontics. Orthodontics is a specialty where a lot more general practitioners are doing it, and there are a lot of changes in that field. In terms of oral surgery, I think that probably will remain pretty independent. A lot of people are doing endodontics now for themselves, especially when they bring in microscopes into their practice. They can do molar endo. So I think all the specialties are beginning to integrate. I think the periodontics is certainly, in my opinion, struggling because they're I don't want to say this carefully. They have debate amongst themselves as to which direction they should go. Should they go towards emphasis on implants? Should they go really emphasize or go back, as some people allege, go back to the philosophy of saving teeth rather than putting implants? So there's a hot debate going on within the periodontics field. I take no position in that. I'm just observing that they have debate and they have different perspectives on the future of periodontics. But I believe that pinhole surgical technique, or called pinhole gum rejuvenation or lunchtime gum lift, can be of help to all the general practitioners who want to take up this technique, and certainly will be great for the periodontists to adopt this technique, because no matter how many GPs I train, not all of them will come. If I get 5-10% in the next 10 years of the 150,000 GPs, you'll be a lot. And the rest of the 80% of GPs, they will want to refer to periodontists. And so there is one way for the periodontist to be very busy for the next generation is to do pinhole surgical technique. That by itself will really, I think, revive the activity, the busyness situation with the periodontal profession.
Okay, I'm down to 3 minutes with you, so I got to ask a question on ethics. I mean, you're a legend in ethics. You teach it at USC. What's the low-hanging fruit on dental ethics? So how would you subscribe it in a nutshell? And what are the things we should be looking out for?
I think that the main concern I see is the lack of understanding of what informed consent means. It's the number one ethics principle in the American Dental Association's principle of the ethics and code of conduct. Autonomy. Patients need to know. And too often, I think we dentists get into trouble because we're a little bit too paternalistic. And we adopt the old models and we can say to the patient what is good for the patient. The current ethics, the current accepted principle of healthcare is that you've got to give the patient total autonomy to pick and choose what is safe and effective. So that means you really have to offer all options, whether you like it or not, whether this is something you do or not. You should offer implants, whether you do implants or not. You should offer fixed bridges, even if you don't feel that there's something that you do well at. Explain all the nuances. If you're for instance, Howard, if somebody's selling a product in the office, the patient should know, according to this principle of ethics, that you are going to make money on it. You should disclose that. So these are all ethical questions, but I think that will keep the doctor out of trouble most of all. Secondly, has to do with advertising, being truthful to the patients, in terms of how you disseminate information. But I think the main thing is you can stay out of trouble if you tell the patient everything the patient needs to know. Give all the options. Doesn't matter whether it's the most expensive or not. Even though you think the patient cannot afford it, you must disclose that option. And also you should disclose the cheapest option, the most inexpensive option that will in some way serve the patient, and let the patient decide based on their own budget, their own priorities, what they want from your dental services. So if there's any advice I can give, I think that would be the overall.
And Dr. Chao, what % of informed consents get thrown out of court because they say, okay, you said on this implant that it could hit the inferior alveolar nerve, and the lawyer says, sir, do you know what an inferior alveolar nerve is? Do you know what a mental foramen is? And they establish that you agreed to an informed consent of all these Latin terms that you don't understand and throw it out. What % of the time do you think an informed consent just gets thrown out?
Okay, before I want to answer the question, I would say the pinhole, there's no safer method than the pinhole in regards to the mental foramen. We have a totally different way. Yeah. But to answer this question, the informed consent is not a piece of paper. The informed consent is basically what effort did you take to really explain to the patient in the language the patient understands all the reasonable options that can that you need to show in those circumstances. So if you just read all the words in the informed consent, that doesn't save you. You need to show that the patient really understood what you're saying and has responded in a way that show that he or she understands. And then finally, the arbiter of whether you have given enough consent is 12 people sitting in the jury of your peers, and they will decide whether you have made the effort in goodwill and the patient has really understood what you tried to say. So a piece of paper will not save us. You have to take the effort.
So we are out of time. So my last question is, when you're at a cocktail party, do you tell people you're a dentist or a lawyer?
I never tell anybody I'm a lawyer.
You never tell them you're a lawyer?
I'm a lawyer.
Well, hey, I just want to tell you.
It doesn't increase my credibility.
I tell you what, you're a rock star. You're a legend. This technique, I mean, you can't throw a cat and see someone talking about this technique. I see it all the time, talking about on Dental Town, social media, everywhere. For you to take an hour out of your day to spend with me, it was just a true honor.
Thank you,
Dr. Chao, thank you so much for what you've done for dentistry, USC, the Pinhole surgical technique, and I hope to see a course of yours on Dental Town in the Pinhole surgical technique and another one in jurisprudence. And on that note, thank you for all you've done.
What you've done for dentistry.
Thank you. And thank you very much. Bye-bye.